Well, good afternoon, everyone. Today, I'm going to do an interview with a friend and colleague, Dr. Cliff Porter, physician here in Austin, Texas. And we're going to talk about COVID, post-COVID infections, and the return to exercise. I've had a couple of my patients who did have an infection with COVID, and now they're a few months out, and they've been asking, when is it, what symptoms should I be looking out for, and is it safe to even do it? So that's why I invited Dr. Porter here. He is the family physician, founder of Texas Direct Medical Care here in Austin, has a great practice over there. And at the end here, I'll definitely let him, if you want to get in contact with him, he'll give his information and such. But he's a wealth of knowledge, former military doctor, ER experience, and just a good person in general. So, without further ado, Dr. Porter, tell us here, what, with COVID and someone who's had a COVID infection, is exercise safe to do afterwards?
Exercise is always safe to do. So the question is when people have the illness, is their exercise tolerance, of course, is greatly reduced, the stress on the body with the illness, but people can always go back to exercise in some form. It's just, some people who are used to being very active and all of a sudden they're limited by the coronavirus, particularly with breathing and fatigue and their exercise tolerance, and their conditioning goes down. It's frustrating for them, so they want to push it harder. Exactly. And then they get exhausted again. And so, as the old baseball coach would say, stay within yourself. And so there's a degree of gradually getting back to it. But for some people who have more lingering effects, which is fairly common in our more moderate to severe cases, there's things that are occurring with this type of illness, the way this virus attacks the body, that has had effects on the symptoms that are different than others. Like influenza, it's a classic respiratory viral illness. Coronavirus isn't really a respiratory viral illness. It's a respiratory vascular viral illness, because it causes a cascade of effects that's leading to symptoms we didn't really expect. So early on, we talked about ventilations back in February and March, needed more vents. But the ventilations didn't really help people recover the way that they would for, say, someone with a bad pneumonia or influenza pneumonia or bacterial pneumonia. So that's where we had to reassess it. And one of the current theories has to do with what's called the Bradykinin hypothesis. And what it is the way this virus attacks the body, the ACE2 receptor, which is part of essentially your blood pressure control system, that's the vascular part. It upsets this normal regulation that the body uses to control blood pressure and blood vessel health, to put it generally. And it seems to be secrete something called hyaluronic acid, which is essentially kind of a thick gel-like substance that's used in knee injections, it's used in cosmetics, but it's a natural substance. And that seems to explain, there's a lot more research going on this, so I might be a little too cutting edge on the research on it. I think this is what the research is showing. But that would explain why the lungs feel so heavy. And so it takes a while for that to clear out, which is why steroids at certain times of the illness are beneficial. Other times it's actually harmful.
Gotcha.
And if you use systemic steroids early, prednisone, dexamethasone, things like that, it suppresses your immune system. Don't want to suppress the immune system. We want to enhance it. That's why we use other combination meds to slow the virus down and get your system ahead of it. But later, when someone's in the ICU, we use dexamethasone. That's helping some. But in the early on, and this might be what really would help your patients and the people who are still having that shortness of breath, heavy breathing, they're getting better. An inhaled steroid at that point might actually be beneficial. And I've done that for a couple of people and helped them get better quicker. It decreases the inflammation and sort of get that help with that lung recovery quicker without doing a systemic steroid like taking a pill, but inhaled. Now you can start running better. So long way, that was a rather long answer to the straightforward question. That's why getting out aerobic exercise seems to have been delayed and harder. So I had one patient who had asthma as a kid, and then she had COVID in March, and it took her a long time, and then she's finally getting better, at being able to get to her exercise tolerance she hadn't had before. Now she's getting back. So we put her on almost like severe asthma COPD type medicines for a little while.
Gotcha. Gotcha.
And she started getting, and then she started getting better and very frustrated. She thought she was going to have bad asthma for the rest of her life. No, it just took longer to get better. So
Sure.
now she's doing better.
And that sounds like a common theme, is that folks are having some of these symptoms that are prolonged, and it's frustrating for them. They don't know, which way to go. Back to your question, seeing that if a runner, for example, were to, have the infection and they want to get back to running, do you think it would be smart, instead of just jumping back into running, to kind of going with maybe starting with walking and kind of building and building an endurance there? Okay, kind of starting.
Yeah. Oh yeah, absolutely. And because the running hard, you're going to put more demand on the lungs, and are you going to cause a little more respiration or just exhaustion quicker? Certainly. So that's where that gradually getting back into it always makes a little more sense. And you can do it every day. Mm-hmm. I have a treadmill at home, and so at the end of the day, when I'd rather sit on the couch and on a baseball game or something, is I can put a wire shelf on the top of the treadmill, just Velcro, put my laptop on, and I can walk, get a little work done, or watch baseball. But I can start getting that exercise going and helping my endurance. And that's just a gentle way to at least do something. Yeah. And you improve that aerobic fitness as the lungs recover, and the lungs are recovering.
Yeah. I definitely agree with you. I mean, I'm even guilty of that as a former triathlete, runner. I've taken a break from it, and I sometimes are like, I want to get right back into running, but I've found out through injury and also just finding out I can get a good workout with walking. I think sometimes we don't give walking as much credit as we should, and how beneficial it is aerobically and such. So let's say we have this let's take, for example, this patient who's maybe been infected with COVID. They're 2-3 months past it. They're still having some, they're noticing some, kind of some breathing issues, maybe even some palpitations. What would you say to them on, like, what are some warning signs, or maybe some yellow flags that you'd say, if you're experiencing this consistently, maybe it's time to, hit the pause button and maybe, reach out to their physician? Any specific symptoms you would be concerned about, or?
One is it's not getting better, or it's getting worse. And definitely if it's getting worse, that's the key thing to see, because you should be gradually getting better. Everyone's recovered from minor things where, they get a flu or something else where you're a little bit better than, it kind of goes a little bit like this as you get better. So some days are better than others, but, the virus tries to counterattack, it's your body's a battlefield with these things. However, if all of a sudden it starts getting worse, the coughing's more worse, the difficulty more breathing, that's where a person has to listen to their body and listen to what their body's telling them. Then it's worth getting a checkout. And quite often that checkout isn't necessarily an x-ray. Sometimes it is. It's just, I can sit and listen to the lungs. Are they getting a full breath? Looking at the oxygen saturation and seeing how well they're actually functionally breathing. It's a very, everyone has seen those little pulse oximeters that stick to the end of the finger. It's measuring what percentage of the red blood cells have oxygen on them.
Right.
It's a very clever test. I mean, I wish I invented it. You'll come to my island, but but it's a very simple test, and it's very accurate. For now, people watching,
you can get those at Walgreens or CVS.
Yeah, you can get this at Walgreens. Don't measure the low number, because if the thing is off your finger, it's going to read 0. That doesn't mean you're not breathing.
Correct.
So measure the highest number. Take a deep breath, measure the highest number, and then you'll see that there's oxygen, what we call gas exchange, going on in the lungs. Oxygen for CO2. And that tells you it's working. If that's consistently low, you wonder why. Is there fluid in
the lungs? And what would you say low is for our folks out there who are, non-medical? What range would you want that oxygen saturation on the pulse oximeter to be?
Above 97. Yeah.
Above 97. Yeah.
Above 97. Now, some people who have long history of asthma or emphysema, they're going to be in a different range. But those people who know they have pulmonary illness. But for someone who's been otherwise healthy, a runner, or, exercise, and all of a sudden their saturation is 92, 94%, that you'd want that evaluated. Now, that's happened a lot in this illness with COVID. People, perhaps because of the hyaluronic acid or other just inflammation in the lungs, they'll have that oxygen CO2 exchange is hindered, and so that drops the pulse ox. And so that's where a couple things we can do actually can help people get better. Maybe inhaled steroids. Sometimes it's just simply an albuterol inhaler, because that opens up the pipes.
Okay.
And now, if someone has fever, shortness of breath, chest tightness, we want to make certain it's not cardiac. There's an old joke in the ER. If someone says they're short of breath, it's really a heart issue. If they say they have chest pain, it's really pulmonary.
Okay.
If your heart's not perfusing well, the brain, you get a sense in your brain that I'm not getting enough oxygen. So the person will say, I'm feeling short of breath, or they have an elephant sitting on their chest. You've heard people say that.
Sure.
That's cardiac. And this illness can cause cardiac issues for people because it does affect the blood vessels. So, more serious things where people feeling worse, chest pain, that requires a good evaluation. With that evaluation, you rule out bad things. Then we say, okay, here's what we're doing. Here we can get done better. Some people do get scar tissue. Some people do get what we call effusions, fluid in the lungs. And all those things can be taken care of.
Okay. Well, this has been great. I really appreciate. Yeah, excuse me. I really appreciate all this information. I think kind of sum up things is, you talked about, folks are struggling with kind of the breathing issues. It sounded also, if they're having, kind of feeling, pressure on their chest, kind of knowing when to maybe it's more emergent versus, where they could call their family doc. And you think that's a good place to start if they're just kind of having some smaller issues. Start with the family doc, and then.
And I know that's frustrating for a lot of people with our current, just kind of how the nature of our healthcare system has come. A lot of primary care clinics, it's hard to get in right away, and they're going so fast. That's why some of us have shifted to the direct primary care model. We can actually people can call, and when it comes to pulmonary issues, telemedicine is a great thing. People can pick up the phone and call me, and I use my own phone half the time. It's really a unique thing with my practice.
You do. When I call you, I get.
I like to talk to you. I like talking to you. But one of the challenges with telemedicine is I can't listen to the lungs.
Gotcha.
I'll do that with asthma patients. I'll actually give them my stethoscope and say, listen to your lungs. And so that they understand what to listen for, and give that, so they can have a better understanding of listening to their body, literally in this case. But if someone's having shortness of breath, I need to listen to every part of the lung to make certain there's not fluid in there, there's decreased breath sounds, or something else going on. Or get an x-ray. Now, x-ray doesn't tell us what's going on the microscopic level. It tells us the big things. Is there fluid on the lungs? Or something else like that. And then sometimes if they're feeling short of breath, I'll just do an EKG and to see what's really going on. But that's where, that it's good old-fashioned hands-on medicine. And if can't get into a primary care doctor, but in this area, because of COVID, we always want to be available for people and help them out. There's gougers out there, sadly. It happens in every crisis in human history. But we're available to help people if they're really concerned. And then sometimes we just get an x-ray. And there's a bunch of places around town where people can get cheap x-rays for like $50 to pay if their insurance is difficult, as many insurance.
Sure. And if folks
popping on my soapbox about insurance.
If folks are interested in talking with you and learning more about your practice and how you help them, I see your card there, or the nice little poster in the back there. Is that a good number to get a hold of?
That's called product placement. It's product placement, Eric.
Love it.
Yes, it is.
So that's a good. Okay, it's that number there. And it's
if people are interested in how the practice works, and I have a little section on COVID in my on my website talking about the medications we can do early as outpatient. txmedicalcare.com.
Okay, great.
And that way people can ask questions for it. And we put a bunch of the links on a lot of the research on there, so people can have their own, they can study themselves and look at things. If they got questions, they can ask me. But I do find when patients, I like seeing my guests, when they're Googling things, or DuckDuckGo or all these other new search browsers, when they're looking online and doing research themselves, 95% of the time they are smarter, they ask better questions, and it improves their health.
Yep. Savvy folks out there these days with their healthcare, and they need to be. So not every doctor office is created equal. That's for darn sure. Or PT out there. So, man, this has been great. I really appreciate your time and the valuable information you've given us. I feel like folks now maybe will have a better idea if they have suffered with the coronavirus or recovered from it and ready to get back to exercise, kind of when to know, what the expectations are, with exercise and the body's reaction to it, and kind of, maybe some yellow flags to keep their eye on, and when to reach out to their family doc, or, if it's more emergent, and go into the ER. So I think you nailed that. So we really appreciate that.
There's ways we can help them out.
Yeah, well, I appreciate it. Well, thanks so much for your time here today, and we hope you have a good day, and we'll talk with you.
All right, thanks, Eric. Take care.